Hi, good afternoon and welcome. Thank you so much for joining us today. My name is Samantha. I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, Leadership Lessons from Baghdad, Managing Through Chaos Under Fire. Before we get started, I'd like to share a few quick notes on how to make the most of your webinar experience today. For audio, if you're currently listening through your computer speakers and would prefer to dial in by phone, simply click the small arrow up next to the microphone icon in the bottom left corner of your Zoom window. Select Switch to Phone Audio, and the dial-in instructions will be provided. We welcome your questions throughout this session. You can submit them at any time by clicking the Q&A icon on the Zoom toolbar. Just type your question there. We'll be collecting them along the way and addressing as many as we can during our Q&A portion at the end of the presentation. Please feel free to utilize the chat box if you have any technical difficulties. Our team is here to assist you. Also, our session is being recorded and we will be sharing it with you after completion. With that, I'm going to turn our presentation over to Robert with BlueStar Telehealth.
Great. Thank you, Samantha. Appreciate the opportunity to talk to you and your team at Florida Association of ACOs. I'm Rob Wray. I'm the CEO of BlueStar, and with me is Dr. Dennis Mihale, our Chief Medical Officer. And we're going to talk to you today about a couple of things, but mostly about leadership under chaotic circumstances. And if any of you have ever been a leader under chaotic circumstances, then this will work for you. So I'm going to share my screen. Okay, Dennis, can you see that all right? All right, this is fast-paced, gang, so hold on to your hats. Managing Through Chaos, Leadership Lessons from Baghdad. We're going to have a 1-minute introduction of the speaker so that when I talk about leadership, you'll understand where that information is coming from. We'll tell 3 leadership stories of about 4 minutes each. There will be a brief commercial break brought to you by the inimitable Dr. Den Mihale, and then 3 more leadership lessons, and then we'll have questions and discussing about whatever y'all want, and then finally we'll have a very brief raffle at the end of the presentation. Okay, so here we go. Leadership intro. On this page, every number represents the number of humans in an organization that I was the leader of at one point. Honor Committee, Chairman at the Naval Academy, Captain of the sailing team, a lieutenant chasing Russian submarines, operating nuclear power plants, coaching Little League Baseball, in business with my brother for many years, recalled as a reservist to Fallujah in Iraq, running a division of a Fortune 500 company, 2-star Admiral in the Navy, running a whole bunch of ships, 180 ships that all looked in funny shapes like this, in the Atlantic, talking to kids at a STEM group with fine young Americans in Djibouti and more fine young Americans in school in Boston and at sea in the Atlantic, in Haiti after the earthquake, in the Western Pacific, in the Persian Gulf. I wrote a book about leadership, which is now a textbook at the Naval Academy and at ROTC programs around the country, running a marathon, running from the Bulls in Pamplona at the South Pole, giving a speech for TV, and now running a company, BlueStar Telehealth. And we don't wear these outfits every day. This was our holiday party. Okay, that's a speaker intro. Now, 3 leadership stories. The first is seek diversity of thought. You've probably heard a lot about diversity and how it makes organizations stronger, but what you want is diversity of thought. And sometimes you get that with diversity of gender or skin color, but sometimes not. We often think that diversity comes merely from gender or skin color or ethnicity, and sometimes it does, because diversity of thought is about diversity in background and upbringing and culture and education. And oftentimes diversity in ethnicity or gender results in those different backgrounds. But If you have a bunch of people that all have identical backgrounds in education, they're not going to be diverse. They're not going to think diverse, even if they're different colors and different genders. Here's an example. Baghdad, 2004. We were trying to keep the city supplied, and most supplies came in by ships to a port on the Persian Gulf. And then we would truck those supplies on trains up to Baghdad. And the problem is, bad guys kept attacking the train. So we were sitting around in the palace in Baghdad trying to figure out what to do. And the entire group up there was all Army. They all had gone to Army schools. And Army doctrine said, to secure each mile of railroad track, you need X number of soldiers. Well, there were a couple hundred miles of track. We didn't have enough soldiers to secure all that track. So they're having a big meeting and lots of folks are working to try to find a solution. And they were all Army except 2 Navy guys, including me. Now, us Navy guys didn't know anything about Army doctrine. We hadn't gone to all the Army schools. We didn't think the way they did because we hadn't been trained the way they were. In the Navy, if you have a ship and it's moving, say, from San Diego to Hawaii, we don't try to keep the entire route from San Diego to Hawaii safe. We just try to keep the area where the ship is safe. We don't care about maintaining security in all the places where the ship is not actually located. So we said, hey, why not put big guns on the front and back of the train and just keep the bad guys away from the train itself? Don't worry about the whole 200 miles of track. Just keep the train safe. This was a different way of thinking that added to the meeting, not because we were different color or gender, but because our backgrounds and our training were different. So the bottom line is seek diversity of thought. Diversity in gender and race and ethnicity and all that other stuff is good if it gives you diversity of thought, but not as an end in itself. From my experience, diverse thought, particularly in brainstorming through chaotic situations, makes for better group decisions. So try to build that diverse thought. Okay, lesson number 2, take advantage of chaos. Let's say you work in a bureaucratic organization, you're at steady state, you're reasonably successful, and you want to do some new or different initiative, and you are trying to push it through your organization. How much work will that be? Probably a lot. You're probably thinking right now about how many meetings and papers and delays and red tape and evaluations. For instance, our little company just made a proposal to a really big company that would make them a lot of money. And the mid-level managers we were working with agreed that it would be great for their big company, but they said they just didn't have the time and energy to go through their crazy bureaucracy to get it up to corporate management, because corporate management was already happy with the status quo. Now, conversely, let's pretend you're in a movie theater and a fire breaks out and people start to panic and one person stands up on the stage and points and says, "Go this way." What would you do? You'd probably go. Well, the first example was bureaucracy, and it was about trying to affect change in a normal, happy situation. The second example with a theater fire is about leadership in chaos. You don't know who that person on the stage is, but it's a crisis, and she seems to know what's going on, so you're following her lead. In a crisis, try to be the person that seems to know what's going on and use it to your advantage. And by crisis, I mean business problems, not theater fires. You know, maybe your business can't hire enough people, or maybe you hired too many people, or maybe you're running out of money, or maybe your regulations are changing, or your competitor is kicking your butt, or something bad is happening to make the folks in your organization worried and unsure. When they are worried and unsure, you can be the sure one. And you don't have to be totally sure. You just have to be a little bit more sure than everybody else. You don't have to have all your ducks in a row. You don't have to know everything. You just have to know more than the other folks, just like that person in the theater. When I got to Baghdad, we were in chaos and crisis all the time. I was a Navy guy operating in an Army world, but I knew what I wanted to accomplish. And I waded into a much larger organization, and I just acted like I had all the authority and the expertise I needed to make it happen. I just started doing stuff and making decisions and ordering people around, even people that I didn't outrank. And people sort of got out of my way. They deferred to me because I seemed to know more of the situation than they did, just like that person on the stage on the theater on fire. In a few months, I finished a huge project that had gone unfinished for years, simply because I took advantage of the total chaos around me and I got shit done. There's a great saying, in the land of the blind, the one-eyed man is king. When all those around you are blind, try to be the one-eyed person. There's another great saying from General George Patton. A good plan, violently executed this week, is better than a perfect plan next week. You can be the person with the good plan, not perfect, but good enough for violent execution. And then last, there's a third good saying from Rahm Emanuel, who was chief of staff to President Obama, and he later became mayor of Chicago. He said, never waste a good crisis. In other words, take advantage of chaos. Okay, lesson 3, and then on to our commercial break. Intentional brainstorming. Avoid simplistic, self-serving solutions. When you have a group of people in an organization with a problem, you should think about solutions to the problem with intentional brainstorming. Now, this may seem self-evident, but in my experience, it hardly ever happens. I've been the boss in huge organizations with huge problems, and I've had staff come to me with 2 options for a solution, and I send them back and say, hey, I want to see the original list of 12 options. And then they can tell me why they narrowed their recommendations to just those 2. When brainstorming, think expansively. Fill up the whiteboard with 10 or 15 or 20 different solutions. When brainstorming initially, don't think about how reasonable or doable the options are. Just list options. And don't be judgmental when someone else suggests something. If you cut them off or suggest that their option isn't a good one, then they'll be silenced forever. They'll never suggest again. Make a big list at the beginning, and then you can go one by one and eliminate options that are not feasible because they violate federal law or the Newtonian laws of physics. The second rule of brainstorming is to identify a solution, but avoid self-serving solutions and options. There's a great saying, to a hammer, everything looks like a nail. In healthcare, you've probably heard that when a team of doctors are reviewing options for a given patient, the surgeon is always going to vote for surgery. When I was in Baghdad, we had recently won the war, and Saddam Hussein was no longer a threat. And our job now is to try to rebuild the country for the Iraqi people. We were rebuilding bridges and power plants and schools. The problem was, as in the train episode I told you about a few minutes ago, bad guys were attacking these construction projects. The projects weren't being executed by soldiers, they were being executed by contractors, people who built roads and buildings and such. So a lot of these contractors were going to paint a school and then getting shot at and getting killed, and the projects weren't getting done. The president and Congress were naturally unhappy, and they asked Pentagon to fix the problem. So the Pentagon sent a message to all the Army generals out there in Baghdad and said, hey, what's your plan to fix this problem? Well, think of the on-scene Army folks as a hammer, okay? And when asked, they did what Army brass usually does. They didn't do any brainstorming. They just asked for more troops. They thought simplistically along typical Army doctrine. Well, our doctrine is that it takes 100 soldiers to secure a site, and there are 500 construction sites planned, so we need 50,000 new troops. Well, that would have doubled the American troop presence in Iraq at the time, and it was a complete non-starter. It was a simplistic, self-serving response. I got a team together and I did some real brainstorming, which I won't detail for you now, but we came up with a plan to secure the construction sites with only a few thousand new troops, most of which could come from forces that were already stationed in Iraq. We floated our plan up to the 4-star in charge, and it was shot down. They submitted to the Pentagon the stupid, simplistic plan instead, which then got shot down by the Pentagon. So maybe your problem won't be reconstruction of a war-torn country, but the same rules apply. Brainstorm freely and beware of folks in the decision apparatus that will all want to choose the simplistic, self-serving solutions. Be careful of hammers because they're always looking for a nail. Okay, I will be back after a word from our commercial sponsor, Dr. Den Mihale. Den, you're on mute.
Hi, I'm Dr. Dennis Mihale. I'm the Fractional Chief Medical Officer of BlueStar. I've got a pretty simple role: improve the quality of life for patients, reduce the total cost of care, and enhance payment integrity. BlueStar's role is pretty straightforward: connect clinical caregivers with their patients in their home, improve engagement and enrollment in value-based care programs, and provide monitoring, logistics, and support. If you do all those things, you wind up improving the quality of life of patients and reducing total cost of care and enhancing payment integrity. So I love that. Next slide. These are the services that BlueStar provides. I would ask you to take a minute and rank them. Pick the top 3. Not the ones that Dennis would pick, not the ones that Rob would pick, not the ones that BlueStar would pick. The ones that are most beneficial to you and to your organization. The nice part about this is you can look for things that are gaps. You can look for things that are pain points. You can look for things that are opportunities. And you can pick those 3. Almost every one of those, in one way or another, supports population health. If ED visits a problem, then the number 1 item is there, and everybody knows I'm an ED doc. If readmissions are a problem, then transitional care management might be it. Again, think about the problems, the pain points, the opportunities, and choose the 3 that make the most sense for you. Next. Again, being an ED doc, I'm very sensitive to ED use, especially when it's inappropriate or avoidable. In this situation, if you look at ED visits, about 3% of the patient population consume about 30% of ED visits. That top 3%, we used to call them frequent flyers before we understood that access was the issue. They did not really want to be in the ER at 4 in the morning waiting for hours. So our solution is a care coordination team that trains the patient on alternative forms of care. We call, text, email, but the thing that makes the best impact is a button in the home for direct advice, goes directly to a nurse. On that phone call, the nurse can help the patient decide, do they need to see the patient today? Is it a next day visit? Should they do an urgent care visit? Can they handle the problem at home with the advice and support of the nurse? Or do they need to go to the ED? And it's a lot more comforting when you're talking to a trained nurse and he or she can give you the support of what makes the most sense. South Carolina, 63% of direct advice calls avoided an ED visit. That was a study that they did exactly this. I think a lot of you would love avoiding 63% of ED visits in your high utilization. Here's the great part though. If all you did was reduce ER visits by 5% in that top 3%, the program breaks even. I want to repeat that. Not 5% of everybody, just 5% of the people who are frequent utilizers of the ER. Yeah, a 20% reduction would result in $4 savings for every dollar invested. 30% 6 to 1, 40% 8 to 1. And a 20 to 40% reduction is very realistic. You not only improve the quality of life for the patients and improve the quality of care, but you also wind up reducing total cost of care. Next. One of the toughest things for docs is to try to get their high blood pressure patients, their hypertensive patients, to be compliant and take high blood pressure seriously. Why? There's no pain. Their blood pressure is high, and unless they get into a hypertensive crisis, they're not feeling anything. It's not like other diseases. They're not thinking about the possible stroke or heart attack that could happen. They're not thinking about the impact on vision and kidneys 10, 20, 30 years down the road. Really, really hard. One of our clients reported that 70% of uncontrolled hypertensive patients were brought into control. Not only does this improve the quality of life today, but really a huge impact in the future, but it also reduces cost because a lot of patients wind up in the ER when their high blood pressure gets out of control and they've got a red alert and they're told, go to the ER. So this is a way that you can address a problem that's really difficult. If you talk to any of your docs, they'll tell you how difficult it is to get patients to control their high blood pressure. And here's a solution you can use. Next. We're done. Back to Rob.
Okay, thanks, Dan. All right. 3 more leadership stories, and then we can discuss whatever y'all want to discuss. Lesson 4, prepare for the black swan. Now, have any of you ever seen a black swan? I never have. They're pretty rare, except apparently in Australia they have a bunch of them. A black swan is unexpected. It's so unexpected, it's kind of a shock. A black swan event is a really unexpected event. So think of unexpected events. You can think of earthquakes or pandemics, and you can sort of plan for those. Now think of an unexpected event that you would never even imagine. Those are black swans. When the US military kicked the Iraqi army and defeated Saddam Hussein, we thought we'd be rebuilding the country and restoring democracy the way that we had done it before. We had done it in Germany, in Japan, in Korea, in Eastern Europe. We had that game plan and that mentality. That was the normal way of business for us for the last 100 years. Win the war and then rebuild to help the people in the country that we had defeated. Well, we never anticipated what turned out to be the primary black swan in Iraq in 2004. We never thought that while we were trying to rebuild a war-torn country, certain people in that country would be trying to kill us while we were doing it. That was the black swan, and it threw us for a loop. For instance, our army marched triumphantly into Baghdad, having defeated their army, and we expected to be greeted cordially, perhaps even as heroes. No. Instead, the Iraqis took to the streets and they started looting everything they could and burning buildings and destroying much of whatever they had. They looted museums and stole antiquities. Their army was gone. The police apparatus had been dissolved. There was nobody to stop them, except perhaps the US Army. The problem was the US Army had never anticipated this outcome. We weren't trained for it. We weren't prepared. It had never happened before. We had no plan for how to turn an offensive army into a police force for a country that we didn't know in a language that we didn't know. So our forces just sat, and sadly, the army watched and the world watched while the Iraqis, who now were freed from the yoke of Saddam Hussein, took advantage of the chaos and the lack of government. They set our plans and theirs back by months and months and months. Black swans are tough to anticipate. I have 2 recommendations. First, consider reading the book, The Black Swan by Nassim Taleb, T-A-L-I-B. Second, read a book on futures analysis. Futures analysis is an organized way of thinking about the future and anticipating potential outcomes so that you can make present-day decisions in a way that will optimize you for the future. The image on the screen is a classic 2x2 quadrant for basic futures analysis. In brief, you think of the 2 most important parameters to your business. Maybe it's interest rates or consumer confidence or the cancer rate or whatever. And you scope out 4 futures depending on the potential outcomes of those 2 parameters. And then you think, okay, if any of these 4 futures might happen, what should we do today to prepare for them? So I could use an entire webinar just explaining futures analysis, so I won't. But go to Amazon, type in futures analysis. There'll be dozens of books on the topics. If you read any one of them, you'll be way ahead of your peers. So there is a black swan out there in your future, ladies and gentlemen. It's waiting to pop up and catch you by surprise. If you can, try to prepare for it. Lesson 5. Think teams of teams. In the old days, a boss would be in charge of a bunch of people who were all together in an office or a clinic. And the boss would have a boss, and the org chart was simple. It was a command chart, just like that shown on the left. And that's how people think the military is, and at some junior levels, they're right. It is that way. But the higher you go in any organization, the further you get away from that simple command structure. Now, Now life has on-site people, virtual people, hybrid people, full-timers, part-timers, W-2, 1099, contractors, vendors, partners. And so the old straightforward command structure rarely exists. Now running any modern organization of any size is about managing a bunch of teams. Each of your vendors is a team. Your practices are a team. Sometimes they have multiple teams within them. Your regulators are effectively a team. Your accounting folks are a team. Your legal folks are teams. So if you're the boss of an ACO, you might be in command of teams, as shown in the center graphic. But imagine being more senior than the boss of an ACO. Imagine being governor or the head. Oops, sorry, didn't mean to do that. Did I lose the screen that I was on? Oh, sorry. Are we back to the normal screen there view, Dan? Imagine being more senior than the boss of an ACO. Imagine being the governor or the head of CMS or the head of the Federal Reserve or the Secretary of Health and Human Services. Or, like General McChrystal found, the 4-star at the head of a coalition of nations. Then you're trying to manage a bunch of teams that you don't really control. That's a team of teams. When I arrived in Baghdad, I was put in charge of contractor security. Remember I told you about all those contractors going out to build bridges and paint schools and they were all getting attacked and killed? Well, they hadn't figured out the problem when I got there. I was a Navy nuclear engineer. Frankly, I didn't know shit about contractor security, but it was chaos. And in that land of the blind, I quickly decided that I would be the one-eyed man who was king. Our solution was pretty simple. Get all the teams that we didn't control, convince them to all get into the same room together to work out a common solution, a common purpose. We had American military, which was a team of teams all by itself. We had military from a bunch of other nations. We had the UN, the Red Cross, a dozen other major non-governmental agencies. We had dozens of different contracting companies, as well as the security companies that were trying to protect the contractor companies. We had the Iraqi government and their police and their village elders, and nobody was in charge. There was no one entity in charge. We were a team of teams. We put everybody we could think of into this huge operations center, and we made them stay there all day, every day, and we worked out the problems one by one. It was not easy. I remember mentioning to a colonel that worked for me, this is like herding cats. And I used the F-bomb several times in that short sentence. He said, sir, this isn't like herding cats. This is like herding cats into an ocean that's on fire. A few years later, when I was an admiral and the Somali piracy problems were at full blast, we had a similar problem. Many, many constituents, but no one in charge. We had 25 navies working the problem, the UN, the EU, NATO, shipping companies, the Indians, the Chinese, insurance companies. Everybody wanted to solve the piracy problem, but we were teams of teams who had to figure out how to do it without any single boss. There was nobody in the world, even God, that we all reported to. We all met for the first time in the British bar in Qatar. Everyone was in civilian clothes to emphasize that we were all peers looking for a solution. It looked like the bar scene from the Star Wars, and it was helped by the British gin that was amply applied in the British bar. But it all worked out, and eventually we solved the problem. So read General McChrystal's book. It's worth it. And it can discuss this concept of teams far more completely than I can in the 4 minutes of this seminar. Okay, item 6 of 6, and then we're done. In Baghdad, in the previous lesson, we coalesced many teams around a single idea, figure out how to keep contractors from getting killed while they tried to rebuild Iraq. This story in lesson number 6 is about Haiti, not Baghdad, but it's illustrative and it emphasizes another primary point. In 2011, there was an earthquake in Haiti. Haiti had about 10 million people then, and 300,000 died. That's 3% of the population. Imagine an event that killed 3% of Americans. That would be 7 million Americans. Remember Hurricane Katrina in New Orleans? 1,000 Americans died, and we still talk about it. So needless to say, Haiti's earthquake was a catastrophe of such huge proportions, it's hard for us Americans even to wrap our heads around it. Now, if you'll remember from your 6th grade geography, Haiti is an island. There are no bridges to Haiti. They had one decent airport and it was knocked out of commission by the earthquake. They had one decent port with one decent pier and it was knocked out of commission by the earthquake. The pier fell into the ocean. America wanted to help, but how? How could we do that? Aha, the president said, let's send a Navy hospital ship. Now, the hospital ship is a 1,000-bed hospital, but it sits empty in Baltimore. We don't have like the whole hospital staffed. The goal is when a crisis hits, we'll crew up the hospital and crew up the ship and we'll gas it up and we'll drive it where it needs to go. And we practice that transition from being in mothballs to being underway. And the goal is to do it in 5 days, but we usually couldn't do it, but that was the goal. No one had ever done it in fewer than 5 days. So I was the admiral that happened to own the hospital ships when the earthquake hit. I got the orders on a Wednesday morning to get underway ASAP to help Haiti. And I said, yes, sir. I counted out the days and I said, all right, we'll be ready to get underway on Monday morning. Word got passed up the chain to the president and they sent the word out to the world that on Monday morning, the Navy was sending, or America was sending a hospital ship to Haiti. I sent out a bunch of orders and we started the process. Our first huge challenge was the ship happened to be in a maintenance period. The engine wasn't ready to go. We were working on it. So I started throwing dozens of engineers at that problem. Imagine breaking your arm, running across the street to your neighbor saying, drive me to the hospital, and him pointing at his car engine sitting on the driveway next to his car, which was undrivable. It was sort of like that. The second challenge is that when faced with the pressure to do something fast, our national authorities pushed the Monday departure back to Sunday and then back to Saturday. So now we were being asked to do in 3 days what had never been done before in 5 days, all with a broken ship. And the third, and ultimately the biggest challenge, was that while we were trying to restore the ship so quickly, a turbine generator exploded. And the good news was that no one was killed. The bad news was that it permanently knocked out all power to the hospital part of the ship, which is a hard way to run a hospital with no power, but that's a sea story for a different day. So in 3 days, we had to get over 100 different organizations to cooperate to fix the ship, to get it fueled and operational and full of supplies and pharmaceuticals and get it staffed with over 1,000 skilled personnel. And these were all people with day jobs. The hospital ship is staffed from people all over America, and it's effectively a moonlighting gig that they do in addition to their regular job. They were scattered everywhere. So how to do this? We had a 5-word mission statement. Underway Saturday morning, help Haiti. All during those frantic 72 hours, I had many people come to me, the boss, and ask for guidance or direction on what to do next. And I just repeated our mission. I said, we're getting underway Saturday morning to help Haiti. Do what you got to do. I'll provide top cover if required. Do you have any questions? I remember calling the 2-star admiral in charge of the Walter Reed Medical Base in Washington. I told him, hey, I'm sending over a truck and I need you to fill it with drugs. And we're going to load it onto the hospital ship, which is leaving in 24 hours. And he said, what kind of drugs? And I said, how the hell am I supposed to know? I'm a nuclear engineer. You're the hospital guy. Just bring drugs that people in an earthquake might need. I said, underway Saturday morning, help Haiti. So the takeaway, ladies and gentlemen, is that simplicity and clarity of a single, straightforward, short mission statement allowed thousands of people across dozens of organizations to synchronize their efforts to achieve a common, hard goal without central direction. It was kind of like ants building an anthill. So next time you got to do something important enough to be the main thing, think up a 5-word mission statement or maybe a 10-word mission statement and get everybody keyed in on that. And for more information, my favorite book on this idea is The One Thing by Gary Keller. There's a bunch of books on Amazon about this, but that's the one that I like the best. Okay, that's the end of the second set of lessons. And so now we will answer any questions that you folks might have.
What a great presentation. I personally thoroughly enjoyed listening to that, and you're such a great speaker. One of the questions that I have for you is, can you tell us about recent CMS changes in reimbursement for these in-home efforts?
Sure. In brief, 10 years ago, CMS did not reimburse very much for in-home care for chronic conditions. The American healthcare system classically 20 years ago would not pay a penny to help a geriatric with hypertension manage her hypertension, but it would pay $1 zillion once she had her stroke from lack of control of hypertension. We're getting better now. And so CMS started a few years ago to say, hey, we, CMS, are willing to pay $1,000 a year, roughly, to help manage the hypertension of this geriatric hypertensive person. And then we can reduce the risk of stroke and heart attacks, which will be good for the patient and also good for the overall healthcare system. So they started with just a couple of them, like chronic condition management, and then they've added remote patient management, and now they've added a number of other codes, all of which involve the care in the home as preventive care. And so every year for the past 6 years, they have added more codes to further flesh out this idea of taking care of folks in the home. And so when the CMS list comes out every January, there are new codes, which means there are new ways to be reimbursed for this care in the home. And that means that the CMS continues to find efficacy and cost effectiveness. Most particularly this past January, the reimbursement for chronic condition management went up again, indicating that CMS likes that happening. And you know what? Only about 2% of American patients who qualify for chronic condition management are getting it. And so CMS is trying to further boost that kind of care. So I don't know if that answered the question or not, Samantha.
No, that definitely did. It gave me a better perspective on it. Can you explain a little more about the ED avoidance program and how it works?
Sure, Dan, I'll just jump in on this if that's okay. In South Carolina, a few years ago, they did a big study with lots and lots of folks, and they realized that people are going to the emergency room or to the ED when they don't know what else to do. And some cultures have a sense of, I'm just going to go to the hospital whenever I'm sick, and the hospital is represented by the ED. But some folks go because they didn't have a primary care physician, or they didn't want to go to a walk-in clinic, or they didn't have transportation, or there are lots of reasons. So the South Carolina study tried to train folks to say, hey, these are the things in which you should go to the ED, but here's your local 24/7 walk-in clinic, and here's an even closer walk-in clinic that closes at 9 o'clock at night. And then, as Dan pointed out, the most important thing that they did was they put a little box in each person's house with a button on it. And it said, anytime you feel like going to the ED, just press that button and talk to our nurse. And as Dan pointed out, 63% of those calls resulted in the nurse recommending that they don't go to the emergency department. Sometimes it was, okay, go ahead and put a Band-Aid on it, or go see your doc tomorrow, or this isn't an ED visit, this is go see your walk-in clinic. And so a huge reduction in getting people at that moment to be talking to someone other than the ED. So it's not really an ED reduction program, it's an ED avoidance program. And it costs, and these are very rough numbers, about $3,000 for an ACO on average for someone to go to the emergency department, and call it $500 on average for someone to go to a walk-in clinic. And so if you can send people to walk-in clinics instead of emergency departments, then that's a great savings to an ACO. And that's why the project has such a great return on investment. Dan, any other thoughts on that before we send it back to Samantha?
I would just tell you, if you really want to make this effective, talk to your physicians and explain to them the importance of same-day, next-day visits. A lot of them don't want to schedule someone in there, but ask them how they feel when the patient goes to the ER. And they can do what one of my docs did, a secret shopper. He had someone call in as the relative of a patient asking for a same-day, next-day visit, and they got an appointment 3 weeks out. He went and talked to the front office, and today his office has same-day, next-day visits, and his ER utilization has gone down. Back to you, Ron.
Because again, the idea is that people say, I got to be seen today, and if my doc won't see me today, then I'll go to the ER. And so I appreciate you bringing up that point. I'm sorry I left it out. Okay, back to you, Samantha.
No, I will concur that same day, next day appointments are key for successful ACO. The last question I did have for you today is, can you discuss your hypertension study a little bit more and give us a little bit more in-depth insight?
Sure. Several years ago, HRSA, the Health Resources Services Administration, had grants that they were giving to FQHCs, federally qualified health centers, to combat hypertension in rural, low-income areas, which were often areas of people of color. And so we were working with a number of FQHCs, and at some point we had about 6,000 people that we were supporting in this program. And in general, what we did was we gave them all a cellular blood pressure cuff. The cellular cuff transmitted the data to our clinical care team, and then our care coordinators interacted with those patients through the course of the month to help them manage their hypertension. And so the measurement, the external coaching, resulted in better behavior. Some folks that weren't taking their medicine regularly started taking it. Some folks started using less salt. Some folks went on more walks. Some folks realized that they weren't in control and they went to see their doc and had their meds adjusted. But the net result was the graph that Dan showed you, remarkable changes. And originally, anyone in the study had to have been out of control, hypertensive, as defined by the American Heart Association. And within just several months, we got 50% of that large cohort in control. And in other cohorts, we've seen up to 70% get in control. There's something like 120 million Americans that have hypertension, and half of them, 60 million, are not in control as defined by the American Heart Association. So the whole idea is to get people in control of their blood pressure. And we did that very effectively, very repeatedly. There are HEDIS scores that we can calculate to the dollar how many dollars it will take to change the HEDIS scores on hypertension control, because we have a study of large numbers, and it doesn't cost very much. Roughly, it was about $50 a month in order to have those people reduce their blood pressure in that population, which resulted in a reduction in all-cause mortality. It was reduced by 13%. The risk of strokes and heart attacks for the entire group were reduced by about 30%. And for some people in the group, the folks that were the most acutely hypertensive, their risk of reduction, or their reduction in risk, was closer to 60 or 70%. So imagine paying $50 a month and you can reduce an old person's risk of stroke and heart attack by 70%. It's just amazing stuff. And that's why CMS is so keen on these programs. Did that answer your question, Samantha?
Yes, no, it did, and it's another huge component, I think, within the ACO, and so just getting that bird's eye view was great to hear.
Should we move on to our raffle, or do you want to do more questions?
That's all I had here now. So you want to wrap up? Go right ahead.
Dan, we'll do the raffle, and then we'll each have our final, final comment. So here's our raffle, and we're going to buy dinner for someone in the audience. And our only question is, what would you like to hear more about in the future? And we've listed 12 things there. Well, we've listed 11, and there's a 12th that you can add. And all I ask is that you email me, robert.ray@bluestartelehealth.com, and just say, I'm interested in hearing more about 4, 7, and 9, or I'm interested in hearing more about number 11. And then of the people that respond, we'll pick one at random, and then we'll call them up and say, hey, what's your favorite restaurant? And we'll get you a gift certificate. So please, please, please look at this list, and I'll give you 30 seconds to decide which 1 or 2 or 3 topics you want to hear more about. Scribble them on your notepad, and then send me an email, robert.ray@bluestartelehealth.com. And if you can't find my email, it may be in the webinar invite. If it isn't, I'm sure Samantha will be able to get it to you.
Yes.
Okay. All right, Dan, any final comments from your end, sir?
I spent 5 years as a chief medical officer delivering care in the home. And I can tell you that a lot of people, especially older people, have difficulty getting to the doctor. I asked one of the patient's daughters, and she said the whole thing took 4 hours if the patient got seen within 15 minutes of the doctor. It was about 2 hours to get out of the house and 2 hours to get back. And sometimes that's it's important that they see him face to face, but a lot of times this care can help them take care of themselves, monitor those chronic conditions, provide insight, identify what needs to be done. This is something that's really has a high impact and will move the needle on quality of life and the cost of care. That's it.
Okay, and I would only say that Blue Star is standing by to support your organizations in some of the ways that we've just described. And if you have an itch, please talk to us, and we'll see if we can scratch it. If you have an unmet need, please talk to us so we can see if we can help you meet that. And if you have a particular problem that you're trying to resolve, give us a holler. And the worst we can do is not be able to solve it for you, but chances are oftentimes we can. So, and then Samantha, thank you very much for inviting us today.
No, thank you. Thank you to, Den and yourself for providing this expertise with our members. We truly appreciate it. And just as a quick following up, I will be sending an email with that will include Robert's contact information and Dennis's contact information, should you have any additional questions, along with a link to the webinar recording. So please feel free to share that recording with your colleagues, your payers, whoever may find it valuable. We also appreciate everyone's participation and encourage you to keep an eye on your inboxes. We hope to see you this fall at our conference. And thank you again, Robert and Den, for being part of this wonderful webinar today.
Okay.
Thanks, Samantha. Bye,
Bye-bye.
everyone.
Take care.